Morning, everybody. Welcome to the pharmacology class. I am Dr. Damodari. Today's topic is estrogens and progestins. Estrogen is the hormone secreted by the ovary. Estrogen and progesterone are the hormones secreted by the ovaries. Estrogens are the substances which are having estrogen-like activity, whereas progestins are the substances which are having the actions similar to the progesterone. The estrogen is synthesized in the ovary with the help of the cholesterol. From the cholesterol, pregnenolone is synthesized, and the pregnenolone is converted into androstenedione, and from androstenedione, testosterone is synthesized. From the androstenedione, it can be converted into Estrogen, and from the testosterone, estradiol is synthesized, and the estradiol can be converted into estron, and estron can be converted into estradiol. And from the estriol is synthesized, and this estriol is also synthesized from the estron. So estron, estradiol, and estriol, these three are the gonadal estrogens secreted by the ovary. Estron is the E1, estradiol is the E2, and estriol is the E3. Apart from these three, estradiol is more secreted. The quantity of the estradiol is more when compared to the estron and estriol. And the functional estrogen is the estradiol. Daily secretion of the estradiol from the ovary in females, that is menstruating female, is 10 to 100 micrograms per day, depending upon the menstrual cycle, day of the menstrual cycle. And in men, it is secreted 2 to 20 micrograms per day, whereas in postmenopausal women, the estradiol is secreted 2 to 10 micrograms per day. Coming to the classification of the estrogen: natural estrogens, semi-synthetic estrogens, and synthetic estrogens. The natural estrogens are estron, estradiol, and estriol, whereas the semi-synthetic estrogens are ethinyl estradiol. This ethinyl estradiol is a steroidal estrogen, whereas the synthetic estrogen is steroidal is mestranol and tibolone, whereas the non-steroidal synthetic estrogens are diethyl, stilbestrol, and hexastrol. This is the classification of the estrogens. And this is the structure of the estradiol. It is having cyclopentanoperhydrophenanthrene ring. All the steroidal hormones, they are having this ring structure. This is the cyclopentano ring, and these three combined together are the phenanthrene ring. So estradiol structure is, it consists of cyclopentanoperhydrophenanthrene ring. For this, at the 13th position, there will be a methyl group. If single methyl group is present, it is estradiol. If another methyl group at the 6th position, if another methyl group is present, it is testosterone. So you are having the spotters. In spotters, you are having the estradiol structure and testosterone structure. You have to identify by the presence of the methyl groups. If double methyl group is present, it is testosterone. If single methyl group, it is estradiol, structure of the estradiol. And coming to this is the picture showing the follicle, that is Graafian follicle. The first one is the primordial germ cell present in the ovary under the influence of the follicular stimulating hormone. The follicular stimulating hormone will help for the follicular maturation, for the multiplication of the primary follicle to convert into the Graafian follicle under the influence of the follicular stimulating hormone. And at the time of ovulation, initially low levels of the luteinizing hormone and follicular stimulating hormone are secreted from the anterior pituitary, and they are having their effect on the ovary. So ovary consists of the germ cells, primordial germ cells, and under the influence of the follicular stimulating hormones, these primary unilaminar follicle will get matured, multiplied, proliferated, and attains the Graafian follicles. With the influence of the luteinizing hormone, the Graafian follicle will rupture and releases the ovum. And this Graafian follicle, it secretes the large amounts of the estrogens, which are responsible for the development of the female genital tract. And the after ovulation, the Graafian follicle will become the corpus luteum, and this corpus luteum will secrete the estrogens and progesterones. If pregnancy occurs, the secretion of the estrogens and progesterones are taken over by the placenta. Until third month of pregnancy, the corpus luteum will secrete the progesterone responsible for the maintenance of the pregnancy. After third month, the placenta will take the role of the secretion of the synthesis of the estrogens and progesterones. And coming to the physiological actions of the estrogens, their effect on sexual development, they are responsible for the development of the sexual organs, female sexual organs. Those are uterus, fallopian tubes, and vagina. For the maturation and development of the female genital tract, estrogens are important. The secondary sexual characters, those are the development of the pubic hair and axillary hair, and development of the breast. Enlargement of breast occurs under the influence of the estrogens, and their effects on reproductive tract. They will cause the contractions of the uterus and fallopian tube and vagina, cervix and vagina. And these movements, they will help for the penetration of the sperm to enter into the uterus and enter into the ovarian tube, where the fertilization will occur. So estrogens are very important for the minimal contractions of the uterus, fallopian tubes, and vagina and cervix. And coming to the metabolic effects of the estrogens, they have weaker anabolic effects than androgens. They cause synthesis of the growth factors and enzymes responsible for the growth and development and differentiation of the uterus. And these estrogens, they will increase the plasma levels of the transcortin, transferrin, angiotensin, fibrinogen, thyroid binding globulin, and sex hormone binding globulins. And they have positive effect on bone. That is, they will reduce the apoptosis of the osteoclasts. These osteoclasts, they are the cells responsible for the osteoporosis. They will, apoptosis means cell death. They will lyse the osteoclasts, and they are having anti-apoptosis activity by increasing the osteoblasts and osteocytes. Osteoblasts are responsible for the generation of the bone matrix and development of the bone. And these estrogens, they will help in the fusion of the shaft with the epiphysis. and they will induce the enzyme hydroxylase in the kidney. This hydroxylase enzyme is responsible for the generation of the active vitamin D. This active vitamin D is important for the positive calcium balance. Calcium is important for the development of the bone. So these estrogens, they will induce the hydroxylase enzyme in kidney and helps in the generation of the vitamin D, and alternatively they will cause the positive calcium balance. And effects of estrogens on lipids, they are important for the increase of the HDL levels, high density lipoprotein levels, and total triglycerides, and they will decrease the low density lipoprotein A, and total cholesterol levels. So they are beneficial for the females. That's why the females are less prone for the cardiovascular diseases when compared with the males because of this the hormone estrogens. So the atherosclerotic and cardiovascular diseases in premenopausal women are less because of the increased levels of the high density lipids, high density lipoproteins because of the estrogens. And their effects on blood coagulation, they enhances the coagulability due to increased levels of factors 2, 7, 9, and 10, and they will decrease the levels of antithrombin, that is factor 3. So coagulability is increased with estrogens, and they will lead to thromboembolic phenomena. The other effects are they cause the edema. They increases the intravascular fluid, passage of intravascular fluid into the extravascular compartment. So they increase the extravascular fluid by passage of the intravascular fluid into the extravascular compartment, and there will be retention of the sodium and water. So because of this, they will cause hypertension on prolonged use, and they are having lithogenicity. That means they causes increased synthesis of cholesterol and decreased excretion of the bile salts. Because of increased synthesis and decreased excretion of bile salts, stasis of the bile will occur, leads to lithogenicity. So there will be chances of bile stones, static bile stones will occur with estrogens. And coming to the mechanism of action of the estrogen. Estrogens acts through the estrogen receptors. There are two types of estrogen receptors, estrogen receptor alpha and estrogen receptor beta. Both are having both alpha and beta receptors, and these receptors are the nuclear receptors. Whenever the estrogen molecule comes and attaches to the estrogen receptors, they undergo dimerization. So there may be chances of homodimers or heterodimers. Homodimers means if estrogen receptor alpha, two estrogen receptor alpha are combined, then it will lead to homodimer formation. If one alpha and one beta receptor is combined, then it will lead to the heterodimerization. They either homodimers or heterodimers, they combines with the co-activator or co-repressor on the nucleus. If they combine with the co-activators, gene transcription will takes place. If the dimers, heterodimer or homodimer, if they combine with the co-repressor, then gene transcription, inhibition of the gene transcription will takes place. So these are the nuclear receptors, and this is the mechanism of action of the estrogens. Coming to the sites, these estrogen receptors predominantly present, alpha receptors are present predominantly on female genital tract, ovarian theca cells, breast, hypothalamus, endothelial cells, vascular smooth muscle cells. And whereas estrogen receptors beta are present mainly on bone, brain, prostate, and ovarian granulosa cells. And coming to the preparations and doses, these natural estrogens, they are present as esters. The preparations are ethinyl estradiol. Ethinyl estradiol is available as tablets, micronized injections, transdermal patches, gel form, implants, and vaginal tablets. The tablets are available as 1 milligram and 2 milligrams, whereas micronized tablets, they are available as 0.5 milligrams, 1 milligram, and 2 milligrams. The micronized injection is available as 1 milligram per ml. And whereas the transdermal patch dose is 25 micrograms, 50 micrograms, 100 micrograms, they release these doses for up to 24 hours. And gel form is also available, whereas the implants, the dose of implant is 25 milligrams of the ethinyl estradiol present in the implant, whereas the vaginal tablets consists of 25 micrograms, 25 micrograms of ethinyl estradiol in vaginal tablet. Second preparations are the estradiol valerate. Estradiol valerate is available as 1 milligram tablets and 2 milligram tablets. The third preparation is the estradiol succinate. Estradiol succinate is available as 2 milligram tablet and 0.1% vaginal cream. Coming to the semi-synthetic estradiol preparations, it is available as ethinyl estradiol. That is, they are available as tablets, 0.01 milligram and 0.025 milligrams ethinyl estradiol tablets. Mestranol is a prodrug, and this mestranol is converted into ethinyl estradiol. The synthetic non-steroidal estrogens are the diethylstilbestrol. They are available as tablets, 1 milligram, 5 milligrams, and 25 milligram tablets. And diethylstilbestrol also available as cosmetic preparations and rejuvenating creams. And conjugated equine estrogens. These preparations are mixture of water-soluble conjugate estrogens obtained from pregnant mare's urine. The pregnant mares are having higher amount of conjugated estrogens. So the conjugated equine estrogen preparations are obtained from pregnant mare's urine, available as tablets, injections, and vaginal cream. Tablets are available as 0.625 milligrams and 125 milligrams. These conjugated equine estrogens, they are used for the hormone replacement therapy in postmenopausal women. The dose is 0.625 milligrams. And the injections available as 20 milligrams per 5 ml. That is, each ml consists of 4 milligrams. They are also available as vaginal creams, 0.625 milligrams in 1 gram base. Canesten. The trade name is Canesten. These vaginal creams are used for senile degenerative changes occurs in postmenopausal vagina. So these vaginal creams are used to treat the senile changes occurs in postmenopausal women. Coming to the therapeutic uses, these estrogens are used for the contraception. The main use of these estrogens, along with the progesterones, they are used for contraception. As biphasic or triphasic pills, you will know regarding the contraception in the next class. And the main use is these estrogens are used for the hormone replacement therapy in postmenopausal women, because the postmenopausal women will suffer mainly from the osteoporotic changes in the bone, and the changes occurs in the absence of estrogens in vaginal vagina, and the changes which will occur in the mood. So what are the post-menopausal changes that occur after the cessation of the menstruation? They are: number one is osteoporosis. Number two is the cardiovascular diseases. These postmenopausal women, they are more prone to cardiovascular diseases because estrogens are responsible for the increased levels of HDL and decreased LDL levels. What happened? The estrogens are not present, the HDL levels will decrease and LDL levels will increase, and these people, they are more prone for the cardiovascular diseases. And vasomotor changes like heart flushes occurs in the absence of the estrogens, and urogenital atrophy will occur, and these women, they will suffer with psychological disturbances and cognitive disturbances, and minor changes like wrinkling, skin changes like thinning of the skin, and changes in the urethra, vulva, and external genitalia, decreased in height, all these headache, tiredness, difficulty in concentration, all these symptoms faced by the postmenopausal women. So to treat all these changes, we have to give estrogens if the uterus is intact, along with progesterone. The estrogens are given, and if the uterus is not present, if the person is hysterectomized, only estrogens can be given to treat the changes occurred in the postmenopausal women. The dose of the estrogens here in hormone replacement therapy is 0.625 milligrams per day. If uterus is present, last 10 days, progesterones has to be added along with the estrogens. And coming to the third use is to treat the dysfunctional uterine bleeding. Dysfunctional uterine bleeding is usually menstruation occurs once in a month. If multiple cycles occurs in a month, it will lead to dysfunctional uterine bleeding. It is because of the overproliferation of the uterine endometrium, and incomplete sloughing of the uterine endometrium will leads to dysfunctional uterine bleeding. So these estrogens, they are used to treat the dysfunctional uterine bleeding, and they are used for the treatment of the prostatic cancer. In carcinoma prostate, there will be increased levels of the testosterone. So to compensate the actions of the testosterone, smaller amounts of the estrogen has to be given to treat the prostatic cancer. And vulvovaginitis in children, hirsutism and acne vulgaris. The hirsutism and acne are because of the androgens released, overproduction of the androgens. So estrogens will subside hirsutism and acne. And the other uses are, it is used for the dysmenorrhea. Dysmenorrhea especially because of the ovulatory cycles. The dysmenorrhea means pain during menstruation. So if we use estrogens in menstruating women, what happened? There will be the ovulatory cycles will change into anovulatory cycles. So anovulatory cycles are painless. And the estrogen preparations, especially vaginal creams, are used to treat the senile vaginitis and for suppression of lactation. Increased estrogen levels will inhibit ovulation and it will suppress the lactation. These are the therapeutic uses of the estrogens. And what are the precautions and contraindications of hormone replacement therapy? Hormone replacement therapy should not be done in patients who are having gynecological disorders like carcinoma, breast, and endometrium. Why? Because estrogens will have agonistic action on breast and endometrium, and they are contraindicated in carcinoma, breast, and endometrium, and undiagnosed or unexplained vaginal bleeding. And they are contraindicated in hepatic disorders and cardiovascular disorders. Why? Because hormone replacement therapy is contraindicated in cardiovascular diseases. Why? Because these estrogens, they are having thromboembolic phenomena. They increase the factors 2, 7, 9, and 10 leads to thromboembolism. So they are contraindicated in CVS disorders and thromboembolic disorders and hyperlipidemias. Hyperlipidemias. Why? Because they increase the triglyceride levels, LDL levels, and cholesterol levels. So they are contraindicated in hyperlipidemias. And convulsions. In convulsions, there will be increased intracranial tension, and these estrogens, they will cause the increased levels of the extracellular fluid and reabsorption of sodium and water retention. So they will aggravate the convulsant properties. So they are contraindicated in women who are having convulsions. What are the adverse effects of the estrogens? Estrogens, they will cause in general nausea, anorexia, vomiting, and breast enlargement, mastalgia, cholasma. Cholasma means hyperpigmentation on face. This is because of the increased estrogen levels and increased vaginal secretions and weight gain. The vaginal secretions become watery and profuse under the influence of the estrogens. And the second adverse effect is bleeding irregularities because of the hyperproliferation of the endometrium of the uterus. Irregular bleeding will occur because of the increased blood clotting factors like factor 2, 7, 9, and 10. There will be increased chance of thromboembolic phenomena because of the retention of the sodium and water leads to prolonged use will leads to hypertension. Cholestatic jaundice. Why? Because these estrogens, they will increase the cholesterol synthesis and decreases the bile acid secretion. So it will leads to cholestatic jaundice. And these estrogens, they will cause carcinoma, breast, and endometrium because of the proliferation of the breast tissue and endometrial tissue. Chances of carcinoma of breast and endometrium. So coming to the SERMs. SERMs are the selective estrogen receptor modulators. So these estrogens, if they are used for hormone replacement in menopausal women, they are having their effects on bone. Bone, apart from bone, they are having estrogenic activity on breast and uterus. So there are chances of causing carcinoma breast and uterus. To decrease these adverse effects caused by the estrogens, estrogen receptor modulators are synthesized, and these estrogen selective estrogen receptor modulators, they will act agonistic activity in some tissue and antagonistic activity in some tissue. The SERMs are tamoxifen. First foremost one is the tamoxifen, raloxifen, dormifen, and aspimifen. Tamoxifen is having its estrogenic activity on bone. Apart from bone, it is also having estrogenic activity on breast and uterus. So there are chances of carcinoma breast and ovarian, the uterine carcinomas. So tamoxifen is not preferable. So the next terms that those are raloxifen, dormifen, and spemifen or osmifen are introduced. So this is the diagrammatic representation of the SERMs, that is tamoxifen, raloxifen, and dormifen, aspimifen. So the tamoxifen is having anti-estrogenic property on breast, whereas it is having estrogenic property on bone and endometrium. Whereas raloxifen, it is having estrogenic activity on only bone. So there are no chances of carcinoma breast or endometrium. It is anti-estrogenic in breast and endometrium, whereas tormifen, it is having anti-estrogenic activity on breast, but estrogenic activity on bone and endometrium, whereas ospepen, it is having estrogenic activity on vaginal epithelium, endometrium, and bone. So out of all these things, the raloxifen is the safest one, which is having less estrogen, anti-estrogenic activity on breast and endometrium, but estrogenic activity on bone. So these SERMs are used in postmenopausal women for hormone replacement therapy instead of estrogens. Why? Because to avoid especially osteoporosis in postmenopausal women. Coming to the tibolone. Tibolone is a prodrug. It is a synthetic steroid. This tibolone is having estrogenic, progestogenic, and androgenic metabolites. So this tibolone is used for short-term treatment of postmenopause to arrest postmenopausal symptoms. Number one is to relieve vasomotor symptoms in pre and menopausal women and prophylaxis of osteoporosis in menopausal women. But the treatment should be for a short time because it is having its adverse effects and it should not be used in first 12 months of last menstrual period. Why? Because it is having side effects like increased facial hair, vaginal spotting, and weight gain. And the dose of the tibolone is 2.5 milligrams once daily orally. And coming to the anti-estrogens. Anti-estrogens are the drugs which are having antagonistic activity. These are clomiphene citrate, fulvestrant, and aromatase inhibitors. Fulvestrant is a selective estrogen receptor downregulator. Clomiphene citrate is used for the treatment of infertility because of its anti-estrogenic activity. Whereas aromatase inhibitors, the first generation aromatase inhibitors are aminoglutamide. And second generation are farnesene, pedrozole, proglitimide. The first and second generation aromatase inhibitors are not used because of their adverse effects. The third generation aromatase inhibitors, exemestane, anastrozole, and letrozole are used. Exemestane is the steroidal derivative, whereas anastrozole and letrozole are the non-steroidal derivatives. Regarding clomiphene, I will discuss regarding the clomiphene in the ovulation inducing agents. Coming to the fulvestrant. Fulvestrant is the selective estrogen receptor down regulator. So this is a steroidal drug, pure estrogen receptor antagonist. Its affinity towards estrogen receptors is 100 times more than tamoxifen. Tamoxifen is having estrogenic effects, but the affinity of the fulvestrant when compared with the tamoxifen is 100 times more. It acts by down-regulating the estrogen receptors by inhibiting their dimerization. What happens is fulvestrant, it attaches to the estrogen receptors and it will inhibit the dimerization of the estrogen receptors. The estrogen receptor activity will occur after dimerization only, and this fulvestrant, it inhibits the dimerization and it attaches to the receptor. And what happened if prolonged affinity with the receptors will get down regulated. And the T half of the fulvestrant is 40 days and it is metabolized by the CYP3A4 and excreted in the feces. This fulvestrant is used to treat the metastatic breast carcinomas which are resistant to tamoxifen. Tamoxifen is the drug of choice for the breast carcinomas. If they are resistant to the tamoxifen, then we have to use fulvestrant. The dose of the fulvestrant in advanced metastatic breast carcinoma is 250 milligrams deep intramuscularly every month. Coming to the progestins. Progestins are the substances which are having progesterone-like activity. Progesterone is secreted by the corpus luteum after the induction of the ovulation. The corpus luteum will take the role of the synthesis of the progesterone. If pregnancy occurs, then progesterones and estrogens are secreted by the synthesized and secreted by the placenta, or otherwise the corpus luteum will secrete the progesterone. If pregnancy does not occur, then the next menstrual cycle will. And regarding the classification of the progesterones, the natural progesterone is the progesterone, and derivatives of the progesterone are 17-alpha hydroxyprogesterone acetate, substituted 17-alpha hydroxy progesterone acetate derivatives. Example, medroxyprogesterone acetate, megestrol, and chlormandanone acetate. And the derivatives of the testosterone are ethisterone and dimethisterone. And derivatives of the 19-nor testosterone are norethiosterone, norethiosterone acetate, norethinodril, ethinodiol diacetate, norgestrel, disogestrel, norgestrimate, gestodane. These derivatives of the 19-nor testosterone are used in the contraceptive pills, oral contraceptive pills, because they are lack of androgenic activity. The other progesterone derivatives are, apart from their progesterone actions, they are having androgenic activity, but 19 or testosterone derivatives are devoid of androgen activity, especially norgestrel, disogestrel, norgestrimate, and gestodone are the So coming to the pharmacological actions, their actions on endometrium. They are important for the secretory phase of the endometrium. Progesterones are important for the secretory phase of the endometrium. The vaginal secretions will get turbid and scanty. The vaginal epithelium and secretions become turbid and scanty, so that the penetration of the sperm is hostile. And their actions on mammary gland, they are important for the alveolar development. The enlargement of the breast and SNI development takes place under the influence of the estrogens. These estrogens, they will prepare the uterus for the actions of the oxytocin and progesterone for the implantation of the ovum. So progesterones are important for the blastocyst to implant into the uterus. So the main development of the mammary gland, alveolar development, and secretion of the milk will take place under the influence of the progesterone. And coming to the metabolic actions, they will increase the insulin levels, and they will increases the appetite, and they increases the HDL levels. So the actions of the progesterone are antagonistic to the estrogens. Estrogens will increase the HDL levels, whereas the progesterones, they will decrease the HDL levels. And estrogens are important for the maintenance of the pregnancy. They are having anti-neoplastic actions. The estrogens, because of the proliferatory changes, they will lead to carcinoma of endometrium, whereas these progesterones, they are having anti-neoplastic activity. And coming to the other actions, they will lead to hypnotic, that is sleep. They will increase the sleep, and they will cause the mental depression in especially during pregnancy. The pregnant women, most of the time, they will sleep because of the hypnotic effect of the progesterones. And coming to the preparations and dosages, they are available as oral, parenteral, both oral and parenteral. What are the preparations that are available as oral? Those are dihydrogestone. It is available as 5 to 10 milligrams tablets. The dose is once daily or twice daily. And norethistérone is available as 5 milligrams and 10 milligrams tablets. The dose is same, once daily or twice daily. And ethinyl ustrinol, it is available as 5 to 10 milligrams tablets. The dose is once daily. And the parenteral preparations are hydroxyprogesterone caproate, 250 milligrams and 500 milligrams. And the route of administration is intramuscular. Coming to the oral and parenteral preparation, progesterone is available as oral preparation and as injections. The injections are available as 10 to 100 milligrams, and the route of administration is intramuscular. And the tablets are available as 100 milligrams tablets and 400 milligrams tablets, and the dose is once daily. And the other oral and parenteral preparation is medroxyprogesterone acetate. It is available as injection and tablets. Tablets are available in the form of 5 milligrams and 20 milligrams, whereas injections are available 50 milligrams and 150 milligrams. And the route of administration for injection is intramuscular. Coming to the uses of the progesterones. They are used for the dysfunctional uterine bleeding. Dysfunctional uterine bleeding is, functional uterine bleeding means only once in a month. The cycle is once in a month. If irregular menstruations occur within month, or menstruation occur twice in once in 2 months, it is known as dysfunctional uterine bleeding. For treating the dysfunctional uterine bleeding, progesterones are used. And estrogen withdrawal bleeding, to treat the estrogen withdrawal bleeding, and estrogen breakthrough bleeding. And these progesterones are used for endometriosis. Endometriosis means presence of endometrial tissue sites other than the uterus. So this, if the ectopic endometrial tissue is present, it will leads to dysmenorrhea and severe pain during the menstruation. So to suppress the proliferation of the endometrial tissue outside the endometrium, progesterones are used, and these are used in treatment of fibrostic diseases of the breast. And these progesterones are used along with estrogens in oral contraceptive pills. And progesterone only pill, many pills are also available for oral contraception. And it is used, these progesterones are used for postponement of the menstruation. And these tablets, 5 milligrams progesterone is given to the person who wants to postpone the menstruation, and the treatment should start before the onset, 3 days before the onset of the last menstrual cycle. If menstruation occurs, there is no use of giving these progesterones for the postponement. And for the treatment of precocious puberty. Precocious puberty means early puberty. Usually puberty occurs between 10 to 13 years. If puberty occurs before 10 years, then these progesterones are used for the treatment of the precocious puberty. And these progesterones are used for the carcinoma of endometrium because of anti-estrogenic activity of these progesterones. They are used for the treatment of the carcinoma of endometrium. And in hormone replacement therapy, if the uterus is intact, for the cyclical bleeding, to attain the cyclical bleeding in intact women after attainment of menopause, these progesterones are added along with the estrogens in the last 1 week. These are the uses of the progesterone. And coming to the adverse effects are pain at the site of injection. High doses may cause increased body temperature, headache, breast engorgement, acne, and mood changes. These progesterones, they will increase the body temperature. The exact mechanism of the increase is not known, but they will change the temperature thermoregulation center in the hypothalamus. And prolonged and continuous use will lead to irregular bleeding, amenorrhea, hyperglycemia, and carcinoma of breast. And during pregnancy, if progesterones are used, they will lead to anomalies, including masculinization of the fetus. And testosterone derivatives may facilitate heterogeneity. Coming to the anti-progestins. The anti-progestins are mifepristone, onapristone, lilopristone, esoprisnil, gestinone, and ulipristol. These anti-progestins are used for the termination of the pregnancy as contraceptive. The mifepristone is a synthetic steroidal derivative, completely blocks the progesterone receptors. It is not a pure antagonist, but it is a modulator. Modulator means they can increase the secretion activity or decrease the activity. So mifepristone is a synthetic steroidal derivative, blocks the binding receptors and acts as the antagonist. So the implantation of the ovum into the blastocyst into the uterus will not occur if mifepristone is given. Mifepristone, it will inhibit the implantation of the blastocyst. And the mifepristone acts as a partial agonist test progesterone receptors A and progesterone receptors beta. At higher doses, it acts as anti-androgenic. It causes termination of pregnancy if given within 7 weeks. Effect of mephistophel on menstrual cycle. It inhibits the follicular phase, prevents the mid-cycle surge, and delays follicular development, inhibits ovulation. If it is its actions on luteal phases prevents secretory changes in the endometrium. So in follicular phase, small amounts of the estrogens are follicular stimulated luteinizing hormone is released from the pituitary, and this mifepristone, it will prevents the mid-cycle surge, that is luteinizing surge is prevented, and it will delays the follicular development and inhibits the ovulation. If it's given during luteal phase, it prevents the secretory changes in the endometrium. And if it gives after implantation, it will prevent the decidual formation of the placenta and dislodges the blastocysts. So after implantation, it will prevent the decidual formation within the endometrium. Coming to the uses of the mifepristone. Mifepristone is used for abortion. It can be used alone or along with prostaglandins to induce abortion. The dose of the mifepristone, if used alone, has to be given 400 milligrams per day to 4 days or 800 milligrams for 2 days. If it has to be given along with prostaglandin, the dose of the mifepristone is 600 milligrams followed by 200 micrograms of misoprostol after 48 hours, or by germiprost 1 milligram as vaginal pessary to induce abortion. And second one is the contraception, that is 200 milligrams 2 days after mid-cycle or 600 milligrams within 72 hours of the intercourse, that is post-coital contraception. And coming to the ulipristal, it is a selective progesterone receptor modulator. Just like estrogen receptor, selective estrogen receptor modulators, the ulipristal is the selective progesterone receptor modulator. It inhibits ovulation by suppressing luteinizing surge and interferes with the implantation. So it can be used to control pregnancies and used as the emergency contraceptive. The dose of the ulipristal as emergency contraceptive is 30 milligrams. It has to be taken 70 to 120 hours of unprotected intercourse. Whereas mifepristone, it has to be used within 72 hours after intercourse. Whereas ulipristal, it can be used after 72 hours. That is 72 to 120 hours of unprotected pregnancy. Adverse effects of the ulipristal are headache, nausea, vomiting, abdominal pain, delay in menstrual cycle, and ovarian cysts. The ulipristal can lead to ovarian cysts. So with this, I have completed estrogens and progestins. Go through the textbook. If you are having any doubt, clarify with me. Thank you.